Hello, I'm Heather Marie Schmidt, the Regional Advisor for Pre-Exposure Prophylaxis with UNAIDS Asia and the Pacific and the World Health Organization, and it's my privilege to discuss large-scale implementation of PrEP for adolescents and young adults. In Asia and the Pacific, young people aged 15 to 24 years, which includes both adolescents and young adults, accounted for more than 1/4 of new HIV infections in 2019. The vast majority were occurring among young members of key populations who already experience a disproportionate burden. The proportion is higher in countries such as Myanmar and Thailand, where young people account for more than half of new HIV infections, as well as the Philippines, Laos PDR, and Malaysia, which are all above the regional average. And new infections among young people are rising in several countries, including Malaysia, Papua New Guinea, Indonesia, Pakistan, Fiji, Timor-Leste, Afghanistan, and the Philippines. And compared to their older counterparts, less young people in Asia and the Pacific are reached by HIV prevention programs, have access to HIV testing services, with approximately 1 in 3 not knowing their HIV status, and in many countries, a guardian's consent may be required for testing if under a certain age. Young people have an increased vulnerability to HIV through both intrinsic and extrinsic factors across behavioral and psychosocial, biological, and structural societal domains. Indeed, this vulnerability is not equal within the group. A 15-year-old is at a very different point in terms of development, social position, health and literacy, and cognitive skills, independence, including financial and legal independence, behaviors, etc., than a 20 or a 24-year-old. And this is important for providing clinical care and support, as well as planning for HIV prevention programs at scale. With adolescent and young adults' high risk of HIV acquisition and vulnerability, there is an urgent need to add new tools and enhance HIV prevention efforts. WHO recommended PrEP in 2015 as an additional HIV prevention choice for people at substantial risk as part of combination HIV prevention approaches. There are a couple of things that I want to emphasize here. PrEP effectiveness is correlated with adherence, and it is highly effective if taken correctly. PrEP is also an additional HIV prevention option. It does not replace condoms and lube, harm reduction testing or treatment. It does not protect against other STIs or against pregnancy. And it is a package, not a pill. But it is an empowering, appropriate, and responsible option for people to take control of their sexual health and HIV risk when other prevention options are not being used. And going beyond individual effectiveness, one of the major benefits of PrEP is that it can have a population-level effect in reducing new HIV infections if rolled out rapidly and at a large scale to achieve high coverage among those at substantial risk. And this has been shown in Australia, the USA, England, and Scotland. In 2018, the US FDA expanded its approval for TDF-FTC for use as PrEP to include adolescents at risk who weigh at least 35 kilos. Later that year, WHO released a PrEP implementation tool module to support the establishment and delivery and scale-up of PrEP services for adolescents and young adults. The available data from several safety trials supports the safety of PrEP for adolescents weighing at least 35 kilos, previously a key concern for providers. And although the clinical recommendations have typically taken a cautious approach, which includes close monitoring for mineral bone density and kidney function, etc., the available evidence suggests that any changes are small and reversible. However, high adherence is essential for PrEP to be successful. And numerous studies and implementation data suggest that young people may experience greater difficulties with adherence and continuation on PrEP over the longer term. Adolescents may require additional support, more frequent visits, and other interventions including peer support, text messages, reminders, and youth-friendly clinics to support continued adherence and continuation. Many countries in the Asia Pacific do not have a specific age for eligibility detailed in their PrEP guidelines. And so while this doesn't prevent PrEP access per se, not mentioning adolescents is not necessarily encouraging or enabling for providers. And in practice, low numbers of adolescents have been provided with PrEP across the region. And of course, any age-based restrictions on HIV testing can also prevent access. This is because HIV testing at baseline and regularly thereafter is necessary to start and continue PrEP safely. Several countries do allow clinician discretion in the provision of PrEP, but cautions that PrEP should be considered on a case-by-case basis too often create or reinforce an uncertainty or resistance to providing PrEP to adolescents with substantial HIV risk in unexperienced providers. The scale-up of PrEP services is not possible without guidelines, regulations, and laws that not only enable young people at substantial risk to access PrEP, but actively facilitate that access as part of a comprehensive package of sexual health services. I need to acknowledge that there is not a lot of data for large-scale PrEP implementation for adolescents. Right now, there is only limited large-scale rollout of PrEP in our region generally, and a lot of the focus on adolescents and young people has been on assessing safety, acceptability, continuation, and adherence. However, Thailand has done quite a bit of work, but even within Thailand, the concerns about the provision of PrEP to adolescents continues. A recent PrEP pilot project in Bangkok aimed to contribute to the data on feasibility and clinical concerns in providing PrEP to adolescents. And they enrolled 50 participants aged 12 to 19 years between January 2019, with the last participant completing 6-month follow-up in March 2020. There were a couple of key takeaways from this study. Retention was high, and this was related to youth-friendly services and the empowerment of clients to take control of their own health. The study also supported data on PrEP safety, finding no SAEs and no seroconversions. And they also found no changes in condoms or STIs in the cohort. However, consistent with other studies, adherence was suboptimal, and particularly suboptimal on self-report, and it required additional support. The study made a couple of recommendations to support best practice in implementing PrEP for adolescents and young people. And this included a comprehensive approach to adolescent care that integrates PrEP, the use of a case manager to create trust and facilitate smooth surface access and referrals, and crucially, ensuring adolescent-friendly youth services. And these results are further supported by implementation research by Song Tuisen et al., also in Thailand, which found that youth-friendly services were important for retention and adherence among adolescents accessing PrEP. The Chulalongkorn Adolescent PrEP Service began in 2017, and since that time they've had a steady increase in PrEP users with over 400 people to October 2020. And while this slide does not detail the full range of service adaptations and improvements that the service has made, the approach that they adopt towards adolescent PrEP has gone beyond what we might think of as a youth service to adapt to prioritize a convenience store mentality that is quick, highly convenient, and free or inexpensive, but still supports the continuum of high quality care and continuous quality improvement. Under Vietnam's PrEP program, the majority of PrEP users are men who have sex with men and are aged under 30 years, with nearly 40% of men who have sex with men receiving PrEP being adolescents or young adults. This is a younger cohort than has been typical in places such as the US, the UK, Europe, and Australia. Vietnam's P4P program has reported that continuation was positively associated with increasing age, which is similar to what we've seen in Thailand and in other places. However, adherence has been reported to be generally high among men who have sex with men. And Vietnam's approach has been largely youth-friendly, which would help explain the large numbers of young people recruited to PrEP. Services offering PrEP have been largely key population friendly or run. Civil society has been heavily involved, and the approach to community mobilization and communications has used new media, including social media. PrEP is also low cost, and they've added a chemsex or harm reduction or counseling component to further tailor to the needs of different young men who have sex with men PrEP users. And so as PrEP programs are expanded, begun, or planned in Asia and the Pacific, and they are being, as you can see on this slide, adolescents and young people must be central to the considerations. In several countries, PrEP is also just too expensive for many young people who would benefit, even where PrEP is available. Young people have typically more limited financial resources than their older counterparts, and this is especially true for adolescents. Additional costs such as transport, consultation fees, testing may make even subsidized PrEP unaffordable, and this must be carefully examined in PrEP program planning to avoid perpetuating and compounding inequities in HIV vulnerability. PrEP service delivery approaches need to be developed to prioritize young people's needs and preferences, adding choice and flexibility to the models of care and putting them at the center. So while this is not an exhaustive slide in any way, going forward it is useful to consider PrEP programs and their features in terms of who, when, where, what, and how as programs are being designed and developed. And this includes active facilitation of adolescent and young people's access, training for providers to ensure youth-friendly, culturally competent, and sensitive providers and support staff, convenience and express appointments with same-day initiations for PrEP, clinic hours and locations that are friendly to youth, integration of PrEP prioritized into services that are acceptable to, used by, and ideally preferred by young people. And this may require expanding PrEP provision outside the HIV domain, and shifting the focus to prevention effective adherence for counseling, monitoring, and adherence, offering flexibility in the dosing options available where safe and appropriate to do so, and being clear that as risk changes, adolescents can be supported to safely start, stop, and restart PrEP. Innovating in service delivery to increase confidentiality and convenience, including with telehealth consultations for young people. And this is being increasingly used here in Thailand, in the US, the Philippines, Vietnam, in just a few examples. And factoring in the cost of PrEP in that program planning, including indirect costs to the young person. Youth services and PrEP programs can and must be co-designed with young people who are the end users, who may identify issues and opportunities that are not apparent to the providers and policymakers who are generally adults. And it's important that new modalities for PrEP are included in the planning for services for young people, and that includes injectable PrEP. Last year, the two landmark studies, HPTN 083 and 084, in MSM and transgender women and cisgendered women respectively, found that injectable cabotegravir administered every 8 weeks was superior to standard oral PrEP. There are 2 ongoing studies of CAB-LA in adolescents younger than 18 years, with 3 sites in the USA and 3 international sites in Johannesburg, Harare, and Kampala. These results are, of course, eagerly awaited. Availability of CAB-LA will increase the range of options that are available, increasing choice, and choice is critical so that people can find an option that fits into their lifestyle without causing inconveniences. And if they're going to willingly use those options consistently and correctly. Injectable PrEP will be particularly welcome in the parts of Asia and the Pacific where there is a strong preference for injectable medications. And injectable PrEP eliminates the need to be adherent to oral medication. And this is particularly useful for young people where adherence has been a particular concern. However, it's still likely to be some time before CAB-LA is available outside trials, as there are some important safety and implementation issues to address before widespread implementation. That does not stop us planning for it, though. So to conclude, expanded HIV prevention programs, including the large-scale implementation of PrEP, in a way that prioritizes young people, is urgently needed to reduce new infections among this group. Without reducing the new infections among adolescents and young people, we cannot hope to end the HIV epidemic in our region. The evidence shows that PrEP is safe and can be successfully used by young people. We don't need more pilots, but we do need services that can better support young people. And these PrEP services must account for the needs and preferences of young people in their design and delivery. Indeed, our PrEP programs generally must do this. And this will often require a redesign or a reorientation of services to make them youth-friendly and more effective. And we can't forget, in amongst all of this, that PrEP is not just a clinical service delivery. We have to remember all of the other things that are successful for programming, including demand generation. Laws and guidelines must also actively support PrEP access, but youth-friendly and youth-competent providers will be a major factor in the success. And finally, a very quick thank you to the conference organizers and everyone who contributed slides and information for this presentation, as well as all of the providers, communities, policymakers who champion PrEP every day.